Skills Lab videos. Newborn assessment. Routine. The routine newborn assessment is completed once a shift and is usually performed in the postpartum unit. This assessment is not as in-depth as the admission assessment and is performed to identify how the newborn is transitioning to the extrauterine environment. This is going to be the assessment that you will be checked off on in the clinical setting and during the skills lab by your clinical instructor. You will still be using the mnemonic Ashla-Gassar to help you guide and organize your newborn assessment. And this mnemonic stands for A, appearance, S, skin, H, head and neck, L, lungs, H, heart and pulses, A, abdomen, G, genitals and anus, A, arms and legs, S, spine, R, reflexes, which will be an area that is not included in the routine newborn assessment. The first step in our procedure is to wash your hands before walking into the room and/or before performing the routine assessment. Introduce yourself to the parents of the newborn and explain that you will be performing a newborn assessment and explain to them what this will include and why you are assessing those areas. Place the newborn on a flat surface at a level appropriate for you to use good body mechanics. We need to find out if this newborn has had their first bath. If they have not, then we need to apply gloves immediately for the entire assessment. If the newborn has had a bath, then the only time we need to use gloves is when we are assessing inside the diaper, when we're coming into contact with blood and body fluids. Unwrap the newborn and check to see if the ID bands on the baby match those that the parents have. We'll start our assessment first by assessing vital signs. The first one will be respirations. Since the newborn is most likely quiet, we can observe the respirations while the newborn is exposed by watching the rise and fall of the newborn's abdomen. The normal rate is 30 to 60 breaths per minute, and it will be irregular in nature. For that reason, it will need to be counted for 1 full minute. Because they are so irregular, you can assess the respirations in one of 3 ways. You may observe the rise and fall of the abdomen. You may palpate the rise and fall of the abdomen by placing your hand over the belly and feeling that rise and fall. Or you may auscultate the lung sounds and count the inspiration and expiration. We'll next assess our apical pulse. We need to count for 1 full minute, and the normal range is going to be between 110 and 160 beats per minute. If the baby is quiet, it can go as low as 90 beats per minute, and if the baby is crying and very active, it can go as high as 180 beats per minute. Next is the temperature. It is no longer recommended to take the initial temperature rectally, as it can cause more trauma to the rectal mucosa. Instead, the recommendation is now to take it axillary. It needs to be recorded and gathered in Celsius instead of Fahrenheit. The normal range is 36.5 to 37.6 degrees Celsius. Blood pressure is not usually done during a routine newborn assessment, but it can be ordered by a physician, so you need to always check the MD orders. If you do see the order for a 4-point blood pressure check, then you need to take the newborn to a separate area and check both the upper extremity and the lower extremity blood pressure at the same time, and pass this information obtained on to the pediatrician or to the nurse that you're working with. Since the newborn is exposed, now's the perfect time to be assessing general appearance. So you want to be doing a once over and looking to see if there's anything that just looks off. We're next going to be assessing the skin. And for the skin, you want to be looking at any birthmarks and newborn rashes. And you can refer to your textbook, pages 679 to 682, where it goes into deeper detail into each birthmark and skin characteristics to help you better identify what is normal and abnormal. It is important to be able to identify Mongolian spots, which can look like bruising. They're most commonly found on the lower back over the coccyx, but they can also be found on the upper arm, on the shoulders, on the legs. So I've seen them in multiple other locations. The reason why it's important to identify this is that it can be confused with bruising, and if the parents take the newborn into the emergency room at a later age, they can think that the child is being abused. When assessing the head, we're looking for molding, which is overriding of the cranial bones during the labor and birth. This is a normal finding, and we just want to see if it's present or not. You should also be assessing for the presence of caput cecindinium and cephalohematoma. Those are both accumulation of either fluid or blood underneath the skin, and that is usually reabsorbed within the body within the next couple of days. They would feel like soft areas on the baby's head. And caput cecindinium, just like the word says, cap, it would cover both sides of a suture line. So it covers both left and right side over fontanelles, where cephalohematoma only is localized to one side. If this newborn does have cephalohematoma, the risk for developing jaundice or hyperbilirubinemia is going to be much higher. We're next assessing for the fontanelles, which are the soft spots on the newborn's head. We should be assessing the anterior and posterior fontanelle, and what we're looking for is to identify if the fontanelles are flat. That is the ideal finding. If they are sunken, then that could be an indication of dehydration. If they are bulging, then that could be an indication of increased intracranial pressure or increased ICP. As we're assessing this, we should also be inspecting the skin of the head for skin integrity. Is there any scrapes, bruises, open skin lesions? And if we do find any of these, we need to make sure the parents understand that they are there so that they don't blame the nursing staff for causing them, and then also chart appropriately what our findings are, as this could have been trauma that the newborn sustained during the birth. After assessing the head, we now move to assessing the face. Now, when assessing the face in a routine assessment, all we're looking at is symmetry on the face. We're also palpating either over the nose or over the newborn's forehead to blanch the skin to determine if the newborn has jaundice, so yellowing of the skin. That's it. That's all we need to assess in the face. We next move on to assess the clavicles. So we want to use both of our hands and touch the clavicle bone to determine if there's any creaking or bulges or anything that just feels abnormal. So we're looking to see if the clavicles are broken or fractured in any way. We are also paying attention to see if the newborn is not moving one side more than the other, as this could be an indication that the clavicles are broken or that there is some damage to the nerve plexus. We're now assessing the lungs, so we need to listen to lung sounds on 4 areas in the front, 4 areas in the back. And what we're looking for is the breath sounds. If you haven't counted respirations yet, now's the perfect time to do it. We then will listen to heart sounds. So we want to be listening for 1 full minute over the point of maximum impact if we haven't done it earlier. We're also auscultating for any heart murmurs that may be audible. Next, we move on to the abdomen assessment. We want to auscultate the bowel sounds. Now, your book talks about auscultating it in 4 quadrants. All you need to do is 2 quadrants for this assessment, and you need to just determine if the bowel sounds are present or not. You do not need to determine if they're hypoactive or hyperactive. We also want to be inspecting the umbilical cord. So we want to do a visual inspection and make sure that it is drying, that it is clamped, that there's no oozing or bleeding. It will not be possible at this point to visualize the 2 arteries in one vein, as the cord most likely is going to be drying. This would be the perfect time to teach the parents on how to do cord care if you haven't done so already. We next move down to assessing the diaper area. So while wearing gloves, we make sure that we identify that the sex that is identified on the newborn's chart matches what we see in the diaper. If we have a boy, what we want to do is visualize the urinary meatus to make sure that the meatus is at the tip of the penis and we do not have any hypospadias, which would be where the meatus is deviated off to the side or underneath the tip of the penis. For a girl, we're just visualizing to make sure that we have the appropriate landmarks, so the labia majora and minora. If you are like me and we've forgotten to assess the pulses, now is the perfect time to be assessing your femoral and your brachial pulses. Next, we're going to turn the baby over and assess the back. So we're assessing the spine to make sure it is straight, and we're also assessing the sacral dimple. Another name for this is the pilonidal dimple. It is normal for every baby to have this dimple, but what we are trying to determine is that the dimple does not burrow through into the spinal canal, as this could be an indication of the presence of spinal bifida. We're also inspecting the patency of the anus by observing it winking at you. You cannot assume that the anus is patent just by identifying that the newborn has defecated, because they can have a bowel movement through a fistula within the vaginal area. So it's very important to visualize this area. If the anus is not patent, it is sometimes associated with other cardiac problems. And this is because the cardiac system and the lower GI system develop at the same time in utero. So if we identify that the newborn has an unpatent anus, we need to let the physician know so they can further do follow-up assessments. We are next assessing arms and legs of the newborn, and we're making sure that the newborn has 10 fingers and 10 toes, no extra digits, and no webbing of the fingers and toes. Reflexes are not assessed on a regular basis during the routine assessment, but they could be incorporated and added to the assessment if you believe that the newborn you're caring for has experienced some central nervous system damage or some trauma that could have affected the CNS. You now have all the needed information to be able to perform a routine newborn assessment. If you have any questions, please make sure to write them down and bring that list of questions with you to the first skills lab during week 1.